In general, the early symptoms of Parkinson's disease will include one side being affected with tremors, slowness, and stiffness on that side. And then later, as Parkinson's disease progresses, balance becomes more involved. In terms of the slowness of movements, people might find that it takes them much longer to do things. Everyday things like putting on their shoes, putting on their shirt, buttoning their clothing, using a key, those kinds of things can take 2-3 times as long. And tremors affect the majority of people with Parkinson's. Usually it starts out again on one side, but it can eventually, people can have tremors on both sides of the body. Typically this is a rest tremor that does not interfere with function, but sometimes the tremor can be more severe and it can affect writing and dressing and other activities. And then one of the other, what we call cardinal motor features of Parkinson's is the stiffness or rigidity, which people can have pain associated with. And sometimes even with tremors, people can describe pain from that kind of a rapid, continuous movement. And in fact, one of the earliest symptoms of Parkinson's disease that people can report is shoulder pain. And we think that that is from the stiffness and slowness that people can have in that one arm. And then the final motor symptom of Parkinson's is what we call the postural instability. So people have difficulty keeping their balance, and they start to have risk of falling. They start to, they may need to use a cane or a walker or other assistive device in order to prevent themselves from falling. And this is a major, as Colleen pointed out, we always, this is really primary in what we do is to try to prevent falls in Parkinson's. And there's different strategies that we use to try to do that. And then there's other areas that can be affected of the body. For example, many people have trouble talking. They have a quiet voice. They have difficulty projecting. They may notice that people are asking them to repeat themselves. And when you ask someone who has that kind of a quiet voice, they think that they're talking normally. So the training, the Lee Silverman voice training, is actually to teach them to yell. So there's different types of therapies that have been developed in order that are specifically focused for these symptoms in Parkinson's. People can have smaller writing, that can be one of the first symptoms of Parkinson's, and they can also have decreased facial expression. Some people have decreased eye blinking. They can come in and say, I have dry eyes. That can be an initial symptom that people have. And Parkinson's here, as we see, can affect many other aspects of life. And so it's really important to understand that when you have these symptoms, they're probably from Parkinson's. And so it's important to bring that up to your Parkinson's doctor. One of the main things that we always ask about is REM behavior disorder, which is when people act out their dreams in their sleep. So normally people are paralyzed when they dream, and half of people with Parkinson's, that paralysis goes away and people actually move and act out their dreams, and they can fall out of bed or hurt themselves. So it's a very important safety issue that we need to address with people. So very important to mention. It's actually one of the earliest symptoms of Parkinson's. Constipation is very common, loss of sense of smell. There can be changes in mood and memory. So there are many aspects. When we think of Parkinson's, we think of only the movement issues, because that's what is really what we can see best visually, but it affects other aspects of life too, as you know. And it's in fact these non-motor symptoms that really have the greatest impact on quality of life in general. Mood issues like depression can be very, very prevalent in Parkinson's. At least 50% in my practice, I would say that it's more than that. And it can be one of the earliest symptoms in Parkinson's. And if people don't recognize that, it can lead to a delay in diagnosis. Because in this case, a lot of the times the depression responds to Parkinson's medications rather than some of the more typical antidepressant medications. So it's really important that people sort of have that in their framework. And in terms of diagnosing Parkinson's disease, we don't have any type of blood test or any kind of diagnostic marker. We now have a DAT scan, which I've been using more and more. Has been very helpful in some tricky times when I'm not 100% sure. But in general, it's a clinical diagnosis. And they've done studies where they've had movement disorder specialists, such as myself, look at 1,000 people and try to figure out who has Parkinson's and who doesn't. We're about 95% accurate in our clinical diagnosis. While someone who is even a general neurologist is much less accurate than that. It's about 70% accurate. So there's a lot more who are missed or who are misdiagnosed or who are diagnosed later than they should be if they don't go to a specialist. In terms of the progression of Parkinson's, we were talking about the non-motor symptoms happening first, and we know that that happens. The REM behavior disorder, the moving and acting out of the dreams, that can happen 15, 20 years before people develop tremor, stiffness, slowness, trouble walking. And in fact, in one study, they followed people for 15 years that had dream enactment, and almost everyone developed Parkinson's disease within 15 years. So it really is one of the first symptoms of Parkinson's disease. Loss of sense of smell happens decades before the movement symptoms start. Constipation, decades before the movement symptoms start. This is really important to researchers who, we're trying to figure out how to prevent someone who has early Parkinson's from actually developing Parkinson's disease. We have to be able to identify people who are 20 years into they're 20 years before they actually get diagnosed. There's many different scales that we use. You might, in terms of our research and also in terms of our language, actually, I think that the Parkinson's community, in terms of the clinicians, are one of the best organized of any other neurological disease and probably any other disease, because we have these very standardized scales. So internationally, I'm standardized in all of these scales. This is all, I completed a test and it's graded, and so every Parkinson's specialist in the world, when we talk about a tremor being a 3, we all know what that means, exactly what that means. We can define what that means. So it's very standardized. There's different staging, and I use this whenever I see someone with Parkinson's. I think about which stage, hone in your staging. And this is from the 1960s, and it still holds true. In terms of people initially have one part of the body involved, and then for most people, but not for everyone, again, everyone experiences Parkinson's differently, but most of the time it will spread to the other side, and later in the disease course, balance becomes more and more of an issue. With Parkinson's, it has as a clinician, it's really a positive thing to treat people with Parkinson's, because we have therapies that really work. And our therapies help people and are able to give them a good quality of life for decades. We have medications that really work, unlike in other neurological conditions where we're very much behind. In Parkinson's, we understand more than almost any other neurological condition, and that's why our therapies are more effective. We understand what kind of physical therapies are effective, and we have some physical therapists here who are going to teach about that. We have surgical therapies, and we have medication therapies, and there's a tremendous amount of research, a tremendous energy in the pharmaceutical world and the research world to develop better and better therapies. So, just to sort of talk about some of the basic biochemistry of dopamine, we talked about some of the, on the left side you have the substantia nigra cells, and on the right side, basically they're communicating, these cells are communicating with each other through this chemical called dopamine. And without that chemical, one cell can't tell the other cell what to do, and that is critical in movement. And so what you have is the development of different types of medications that can mimic the natural process, which has been disrupted by Parkinson's disease. So basically what we do is that we give levodopa. Levodopa is a natural compound, L-dopa. It's in all of our bodies. It's the way that the body stores and transfers dopamine across the blood-brain barrier, into a cell, out of a cell. And so if people don't have enough of their own dopamine, basically that's what Cinemet is. That's what carbidopa levodopa is. It's just a natural chemical, levodopa, and it's taking that chemical. Similar to when a diabetic doesn't have insulin, they need to take insulin externally. And so this is a video of the dopamine molecule. And it's a messenger. It's basically like the postman. It's telling one cell what the other cell is doing, what the other cell is telling it to do. And so this basically just explains the different process. Dopamine is naturally broken down. The body is really, really good at breaking down dopamine. There are these chemicals, COMT and MAO, and their job in their entire life is to break down dopamine. And basically, if someone doesn't have Parkinson's, then there's this really a well-oiled machine within the brain that uses the dopamine, and when it's finished, it breaks it down. But what happens is when people have Parkinson's disease, they need all the dopamine that they can get. And so the MAO and the COMT basically works against someone with Parkinson's because it's breaking down the dopamine that they need. So many of our medications basically work to replace dopamine, levodopa. Dopamine agonists which pretend to be dopamine. And then there's other medications like, is anyone on Comtan? You don't have to, but think about if you're on Comtan or medications like rastageline or selegiline. These are medications that prevent these lifelong actors, MAO and COMT, their job is to break down dopamine. Well, you're blocking them from doing their work. And so you're getting more and more dopamine available to you. And so the medications can be extremely effective at reducing the motor symptoms of Parkinson's disease, as well as some of the emotional and cognitive symptoms of Parkinson's disease. But which medication to choose for an individual person can be very, very complex. And so it's really about getting to know the individual person, what their disease severity is, what their other medical conditions are, what symptoms bother them the most. Depending on someone's age, they can tolerate certain medications and they absolutely can't tolerate other types of medications. And then I would say, unfortunately, a lot of access to some of the newer medications are limited for people due to socioeconomic situations. So basically, we talked about levodopa. Now we're going to talk about dopamine agonists. And these are chemicals that trick the brain. The brain thinks that it's dopamine, but it's really not. So unlike levodopa, which is the natural chemical, these are man-made molecules that look like dopamine. And so basically, the chemical travels and connects to the cell, and the cell thinks that it's gotten a messenger from the other cell, but really it's a medication that we produced and that was taken by the individual. And so there's a lot of the times what we do is we work in connection. People will take levodopa, they may take something to block the MAO the MAO and the COMT. They may take an agonist, and all together, with that kind of a complex regimen, we can get good symptom control. So I always recommend that people have a close relationship with their physician, especially when they're initially starting the medication, because it can be very individual, very, very idiosyncratic. How someone's going to respond, how much medication they need, what combination is going to work best for them, what kind of side effects they're going to have. I think that initially that close relationship is really the secret to success with a medication. And once you have that regimen going, you can be smooth sailing. But in that initial time, it's very important. So we talked about dopamine. This is the most effective medication for people with Parkinson's. This is giving people back exactly what they're missing. It's like a diabetic doesn't have insulin, they take insulin. People with Parkinson's don't have dopamine, they take levodopa. So by far, nothing even comes close to how effective levodopa is. In fact, when we give the right amount of levodopa, we expect a 70 to 100% resolution in their motor symptoms. And that's actually part of the diagnostic criteria. And if people don't get that kind of benefit, then we start to question whether or not they have Parkinson's. That's how effective this medication is. We give it with this other drug called carbidopa, and that actually decreases levodopa from being broken down to dopamine in the blood, because we don't need it in our bloodstream. It actually, I have people say, well, why don't I just take this plant? It has a lot of dopamine in it. The problem is that dopamine in the bloodstream will make you nauseous, lightheaded, very sleepy. It doesn't do anything good in the bloodstream, and it can't cross the blood-brain barrier. The body knows this. That's why it converts dopamine to levodopa when it wants to travel between the blood and the brain. So that's why people have to take levodopa, and they take it with this other medicine, carbidopa, which prevents it from being broken down to dopamine. So when people tell me I took Cinemet and I got really nauseous, I tell them that's because your body is extra good at breaking down this molecule into dopamine. You have these super-powered chemicals that are just too good at their job. So we have to give you extra carbidopa and block them. And if you take Cinemet and you get nauseous, it's because not enough of that drug is getting to where it needs to be, which is the brain. With Parkinson's, over time, the chemical itself, levodopa, does tend to have a shorter and shorter effect. So people can take levodopa in the beginning and it can work 6 to 8 hours. But then later on, it might work only 3 to 4 hours, and people have to take the drug every 3 to 4 hours. And then later on, it might work only 90 minutes or an hour. And that's because it's a progressive condition. And we think of, some people with Parkinson's being levodopaphobic because they delay taking this medication because they think that, and I understand why this would be sort of in a myth about this drug, because over time you do need to take more and more. But it's not because the drug causes that or changes the brain. It's because it's a progressive condition, so you need more and more of the drug. Just like someone with diabetes is probably going to need more and more insulin over time because they have less and less as they age. It's the same thing. We know that if people take the levodopa that they need and are not levodopaphobic, their quality of life is so much better than people who try to delay. The amount of levodopa that you need in 10 years will be the same, whether or not you spent those 10 years not moving well because you didn't want to take the levodopa. It's not going to change. And that, I think, is really, I just want to address that myth that sometimes comes up. So, on time, we would expect people to be moving well, and then when the medications wear off, their Parkinson's symptoms are more expressed. We have different medications in different ways in order to manage that. Again, in Parkinson's disease, we are therapeutically the most advanced, I think, of any neurological disease. So we have many different treatment options and many different combinations to try. Like I say, we have many tools in our toolkit to take out. Dopamine agonist is one of them. Some of you might be on or might have heard of pramipexole, ropinirole, or the Nupro patch. These medications are less potent, but they last longer. Just in general, their half-life, the body doesn't break them down as quickly. And for people with Parkinson's who have more mild symptoms, we consider starting this medication first because they can have more on time because the drugs initially last longer. There are some caveats to these medications because about 20% of people who take this medication develop what's called an impulse control disorder, which is compulsive gambling or shopping. It can be very, very disruptive to someone's family life, and unless the physician who's ordering it specifically warns the person, warns their family, checks in all the time with them about this, it can be hidden for years. So it's very, very important when you start this medication to look for changes in your behavior or in your partner's behavior. And then there's these other medications called MAOB inhibitors. I don't know if people have heard of them, selegiline, rasagiline. They have a very, very mild effect on Parkinson's symptoms. I would say most people, if I start or stop these medications, they don't feel any difference at all. But there's a few people, I would say, maybe like 2-3% of people that I start this medication on, it makes a huge difference. Most people, it doesn't make a huge difference. And so the idea, so some people use them, and I'll talk more about this in one of my later talks, as neuroprotective. There's some evidence that these medications may delay Parkinson's progression. We talked about COMT inhibitors, which basically these molecules, their entire life, all they do is break down dopamine. They're just doing their job. And so we have to block them for people with Parkinson's with these kinds of drugs. And amantadine. Amantadine was initially a flu medicine. And people realized that it's okay for the flu, but it's good for Parkinson's. Much better drug for Parkinson's. And what it does is it controls dyskinesias. These are sometimes people have extra movements. If they've taken carbidopa-levodopa for greater than 5 years, they'll develop extra movements sometimes. And so amantadine can reduce those movements. It can be a really great drug, actually. It can reduce off time and control tremor. This is a drug that, for some people, can be really life-changing. So if people have a lot of dyskinesias, it's worth trying. Sometimes for people over the age of 70, it can cause some side effects, like hallucinations or cognitive issues. So we just have to be gentle as people get older. And anticholinergics, artane, trihexyphenidyl. I like to tell people it's like taking a large dose of Benadryl. So a large dose of Benadryl makes you sleepy. This drug will probably also make you sleepy. But small doses can really control tremor. So it's this very complicated combination that some people need to really manage their symptoms well. Exercise. So critically important, and we'll have some of our speakers talk to you about different types of exercises. I'm certainly not an expert in this, but I see a huge difference in people who come in after they start exercising. I know who's exercising and who's not exercising in my patients. And how about surgery? Deep brain stimulation. So one of the things that my center does is deep brain stimulation. We're one of the largest centers in the world. And so basically this is a therapy where we really need to match the person with the therapy. It's a permanently implanted brain pacemaker. So we need to make sure before we expose someone to the risks of brain surgery and a permanently implanted brain pacemaker, they're going to be a good candidate. But the pacemaker leads go into a very small portion of the brain, a couple millimeters in length is the target. These are areas of the brain that are dysfunctional in Parkinson's disease. And this therapy can be extremely effective if we pick the right candidate. It's important to note DBS is not a cure. It works on the movement parts of Parkinson's. Tremor, stiffness, slowness, and shuffling. Those are the things that DBS helps with in Parkinson's. So a lot of what I do is try to determine who is a good candidate for this surgery. So we always want to know that people have had Parkinson's for at least 5 years, because there are some mimics of Parkinson's that after 5 years turn out not to be Parkinson's, and they do not get benefit from the surgery. We basically want someone who has a robust benefit with their Parkinson's medications, but that benefit doesn't last long. So and we're looking for people who have benefit in terms of their movement, tremor, stiffness, slowness, and shuffling. If people have a lot of balance problems, a lot of speaking problems, emotional or cognitive problems, these are things that DBS will not help. So, of course, we wouldn't offer them the surgery. But basically what the studies have shown is someone's best on time, where they feel their best. They're moving their best, they don't have troublesome dyskinesias. On average, DBS can increase that by 4 to 5 hours per day. And their off time is less severe because they're never really truly off. DBS is always working. So there are specific deep brain stimulation centers. The best centers are multidisciplinary centers in academic programs. We have one at UCSF. There's an excellent one at Stanford. Kaiser has a good program as well. So you really want to go to an experienced person and not sort of the small shop, DBS shop around the corner, which they exist. They exist. But I would just recommend going to a large academic center that is very experienced, because it's all about the experience to know who is the right candidate, and then once someone is implanted, they have to be programmed. So the device itself is an electrical programming. So as a neurologist, we program the device, and we tell people give us about 6 months of programming to get it set right. So you need someone who's going to be very available. We spend days with people, set them at a program, give them some meds, have them go to lunch, come back. We have nurse practitioners. They can spend a lot of time with people. As a neurologist, we have a lot of time. So that's what you really need in order to have a successful outcome with deep brain stimulation. And so caring for someone with Parkinson's disease, I think, is an area that really has been not as well focused on with care, and I think is really, really critical. Care partners do a tremendous job of helping people with Parkinson's live their best life, and so there are now more and more resources to help them, in terms of maintain their quality of life and maintain their health, so that they can have a good partnership and continue their lifelong partnership together. So in Parkinson's disease, there's more funding in Parkinson's disease research than almost any other disease on earth. There's more energy, more scientists doing research on Parkinson's than almost any other disease on earth. It's just absolutely tremendous what's going on. And so you'll hear from some of my research and from some of the other researchers here the work that they're doing. But it's really incredible what's going on right now in the search for different treatments and ways to prevent progression. So right now there's nearly 40 medications that are being developed to treat or diagnose Parkinson's disease. There's also about a dozen medications that are in clinical trials right now to try to prevent progression or cure Parkinson's disease, and that's actually what I'll be talking to you about. There's other therapies, exercise, which has been shown to delay progression of Parkinson's disease. It is the best therapy to delay progression of Parkinson's disease. Deep brain stimulation can be tremendous for the right candidate. Stem cell therapy, gene therapy, and biomarker development. We're now finding ways to diagnose Parkinson's 20 years before anyone develops tremor. So these are really exciting developments in our field. that will hopefully significantly improve the lives of people with Parkinson's. So in conclusion, Parkinson's disease is a serious illness, but it shouldn't control your life. There are many, many treatments out there that can be significantly effective, that can improve your quality of life. There's a tremendous amount of support, tremendous amount of research, tremendous amount of energy, I would say more so than almost any other condition on the planet, to try to help people with Parkinson's live their best life. So I really encourage you to reach out, find these resources. Some of you are already involved in support groups. If you're not, I definitely encourage you to get involved, because they're always inviting speakers and having different programs. Plan for your future, take care of yourself, for care partners as well as for people with Parkinson's. And also really want to encourage you to participate in some of these research efforts. Most Parkinson's disease research fails because they can't recruit enough people to be in the study. So, and I'll be talking about how to get more and more involved in research if you're interested. Thank you so much for your time.
Question?